Welcome to Business Spotlight. I'm joined today by Adrian G. Turner, and Adrian is the CEO of Collins Medical Limited. Adrian, it's good to see you. Welcome to the call.
And you, Kevin.
Now, Adrian, we spoke last week. You shared with me a little bit about what it is that Collins do. I know that you are respiratory specialists. Give us a little bit of background information about the company and you know what it is that you do primarily.
Collins Medical is a company that has been in the pulmonary function testing business for many years. In fact, it was one of the companies that originally designed and set up the pulmonary function testing business. However, it went out of business some years ago, some 25, 30 years ago or so. And the key man behind Collins Medical, apart from Edward Collins himself, was a key engineer called Norm Thomas. And Norm Thomas has been retired for quite some time.
Mm.
And then, while working on a project, he decided that he was going to do a new device for himself and then gather around him the people that he needed to bring that to market. It was originally a project that was inside another company,
Mm-hmm.
but then it was eventually spun out with some of the staff going with us and others remaining. But all said and done, the idea is nothing particularly not particularly different from many good ideas
Mm-hmm.
that there have been from years gone by. But the difference is addressing them with new technologies, new materials, new ways of doing business. I mean, the advances that have been in business practice over the last 30 odd years is just extraordinary.
Mm.
And if you think about the last 200 years, they've been compressed, something incredible, and they're going to keep on compressing. So those development cycles, the cost of materials, the cost of going to market, the access to market is all a dynamic environment.
Yeah.
So bringing those two things together, the general idea was to update the old technology, take a good idea and introduce new materials,
Mm-hmm.
new ways of manufacturing, new ways of distributing, and new ways of managing the supply chain. So going forward, the idea is to have simply about 20 odd people who do upper management and middle management roles,
Mm.
but really having everything else done by experts and specialists around the company, supporting the company. And the main reason for that is that those specialists, they see the whole market, not just the segment that we're in.
Yeah. So basically, you're taking a sound technology that's already proven and established and saying we don't need to mess with that, but actually new opportunities have provided themselves in terms of how they interface with the outside world. So that's around, I guess, software systems, is there AI, those sort of things? Give us an
Right.
insight into
Yes. So
integrations.
you've just identified two of the main problems with the current market offerings.
Right.
One of the biggest problems is the machines that are currently offered by the incumbents in the marketplace are just simply not accurate enough to be able to feed the data into an AI model. So, to be able to feed the data into an AI model, you've got to have good quality data.
Hmm.
And even the current standards that there are for these types of machines are not sufficiently tight to be able to generate that data. So we envisage that once we've entered the marketplace, that the standard will actually need to change for people to be able to rely on the quality of the data that you can put into AI models.
Okay. And how does and the benefit of this at the end users, from the end user's point of view, however you define the end user?
Yes, so the end users are typically technicians working in the hospital, and the way that we have looked to address those issues is so that they can export data out of their equipment into an AI model that then the physicians then use that AI model to be able to diagnose patients more accurately.
Mm.
But that's not all. The other aspects of what we've done is we've engineered the systems so that we've got rid of another major cost as well, which is through engineering out the requirement for service engineers. And that's by having remote access capability and local software so the machines manage themselves. A bit like cars these days, they know what's going on and they communicate that back to base, and then you get a message, from Audi or BMW or Mercedes, whatever, saying, what needs to happen and when you need your next service, or what parts need changing. So having that level of insight means you can also continually improve the device, because at the moment you have situations where someone might use a machine a lot and someone else might use a machine a little. So you can optimize its utility.
Okay. So let's look at how that works in the real world environment, because these devices, they do respiratory and pulmonary diagnosis of
They
patients.
no, they don't do diagnosis, they do measuring.
They do measuring. Right. Yes, of
So
course. Sorry. The diagnosis is done by
the
um, yeah, by the
the
medical.
data is analyzed by the AI,
Yeah.
and then the physician does the
The
diagnosis.
physician does the diagnosis
Yeah,
based on
because
the
the
data.
the the AI model, all
Yeah.
it can do is take the data and make suggestions against correlations that it has from its big data set, and it can say to the doctor, "I think this patient has progressive COPD stage 3. I think this patient has seasonal asthma," based on the numbers that it can see.
Right. But of course, those numbers are far more accurate because of the self calibration and various other things.
Not only that, they're more accurate because at the moment, the way that other people make their machines, they at best they're plus or minus 3%. So
Right.
if you've got two machines on two different locations, they could be 6% out. Well, the therapeutic window is between 7 and 10%. So you've only got to be out on the edge of that, and you're almost out of the therapeutically significant window.
Hmm.
So we have tightened that by making all the parameters of every element of the machine to a point that is plus or minus 1%.
Hmm.
And that's the standard machine.
Yeah.
And then we also do a research version that is even more accurate, that can work to 0.1%. And that opens a huge new way of managing patients, improving patients' outcomes, because the therapy they're having from their doctors can be more accurately targeted,
Hmm.
especially at patients that the doctors don't know what's wrong with them, that something's wrong.
Yeah. So like accuracy is key
It's key.
in those circumstances. Okay. So the way you've explained this, you've differentiated the machines from the other machines that are on the market, and you've done that very, very clearly. In terms of the business model you've adopted, how would you say you've differentiated yourself from the competition in that regard?
So the business model that we've chosen is that because this is a complicated thing to do, um, we are basically going to stick to our knitting. We're not going to try and be involved in AI. We're not going to be involved in data mining, data trawling, data sales, data anything. We'll partner with a partner that does that stuff.
Yeah.
We're also not going to do a lot of the sales and marketing either. That's going to be done by the distributors. And the distributors, they're specialists in their local markets with what they do. So we're not going to be having branches all over the place. And then we're even probably not going to even have our own business development managers either, because we're going to the market with such a better product at the same market price or less than what our competitors are doing, that it has a lower cost of service and maintenance, then they will win tenders come what may. So rather than having the liability of a large field force, we will hire specialists which we can move around for the launch phase only from place to place, from region to region.
Yeah. Okay. And from our conversation earlier, you said that you do regionalize your business, don't you, in terms of where product is developed?
That's correct. So that's on the supply side, not developed, but where it's assembled.
Right. Yeah, it's
assembled. So on the supply side, because some of the equipment is heavy, but it's low tech, we generally choose to make that in market. So because tariffs for different markets are high, say take India for an example, it has 28% import duty on finished goods on the type of product that we produce. So we don't want to be clobbered with 28%. So what we'll do is we'll make the component parts that can be made in India, and then on tenders in India, people can say, dealers can say, this is 30% or 40% made locally, which then gives them the advantage of not having to pay the tax on those locally manufactured components. I mean, we would still engage and control within our quality management system, and this is where your QMS director and COO are key, because you've surrounded the company with experts for supply side, and then you surround the company with experts with manufacturing capabilities, contract manufacturers, and then you surround yourself with experts in all of the outputs and inputs on both sides.
Yeah. Okay. No, that makes sense. Some interesting insights there on the tariffs as well, and how they can impact upon a business. So you're going to go out, and these tenders are obviously going to be really strong tenders because of what you have described above and everything above. So how quickly or how well positioned is the business to scale on that basis? Because it sounds to me as though you've got a really strong USP. Are you possibly in danger of not being able to scale fast enough to meet the demand? What's your view on that?
There is a danger of over trading. And a lot of companies get into that issue of overtrading and getting ahead faster than their capabilities are able to manage.
Yeah.
So we've already got orders. We're already delivering. I think the first delivery is in July. But we're then going to have a respite to measure and feedback and have all of that post-marketing surveillance work to make sure that before other units go out in September of this year, that that everything's hunky-dory, everything's as it should be, and then that we've had time to set up. We will initially set up in one marketplace and then bear the cost of moving components around the world. Subsequently, the heavier components will be made first locally in markets, and then ultimately what we call the brain of the system, which is made in the United States, that'll then be made regionally as well. One of the really big opportunities is that at the moment only about 10% of the market is served by the quality and level of accuracy of the type of machine that we're talking about. And we only have about 4 or 5 competitors in that space. And that space is worth about $350 million a year in replacement products and is growing. But the bigger opportunity is all of the people doing lung function testing using pseudo devices. And what I mean by a pseudo device is that something that measures something else and then uses mathematical correlations to make extrapolations that this is what's probably going on.
Yeah.
And that market is about 4 or 5 times larger. And it's mostly third world, second world, underdeveloped environments, and so on and so forth. For example, the whole of China uses that type of system.
Right.
So the Chinese market, which we all know, is going skyward, would be one of the biggest opportunities that there is for this type of device, because they also have very bad pollution in China, as they do in India.
Yeah.
I mean, I'm also a nebulizer specialist, and in India, every other household has a nebulizer for inhalation therapy. That's some of the highest in the globe.
Yeah. No. Well, you've kind of partly answered my closing question there, which was, what is the future and what are you excited about? And obviously, you've hinted about the scale and the opportunities in countries like China and India. But what else excites you about the future for the business?
Well, the key thing is, what we've tried to do is to make the device that's in between the patient and collecting the data such a lower cost device at the accuracy that it has, that it becomes the obvious device to have.
Yeah.
Because currently the global standard is called GLI, the Global Lung Initiative, but it's done on lots of different machines. It's not particularly accurate, and in fact, a lot of physicians disregard it. It's the best that we've got for now. But if you had a data set that had most of the people, in most countries on the planet, where you could predict in advance by testing people and screening people what the likelihoods were, and also tracing people, for example, like ex-smokers, showing them how their lungs are changing in condition from not smoking or not vaping, or people. It's very similar to what's happening in the diabetes space.
Yeah.
But if you monitor and measure and report accurately, then you change behavior.
Yeah, that is exciting.
Mm.
Adrian, thank you very much for sharing all of that with us today. Fascinating learnings from there, and it's been a pleasure to be in your company. Thank you very much.
And you, Gavin, thank you very much for the opportunity.